Hello everyone, this is Savannah Smith and I'm going to be presenting my literature review on pelvic inflammatory disease. The objectives of my presentation are to review the pathophysiology and clinical presentation, assess the history and physical exam findings, analyze the diagnostic criteria for pelvic inflammatory disease, evaluate differential diagnosis and diagnostic studies, discuss treatment and management goals, review associated complications of pelvic inflammatory disease, examine current evidence-based research, and review referral criteria, patient education, and follow-up. Pelvic inflammatory disease is comprised of a spectrum of inflammatory disorders of the upper female genital tract, which includes combinations of endometriosis, spalpingitis, tubal-ovarian abscess, and pelvic peritonitis. Sexually transmitted organisms, particularly gonorrhea and chlamydia, are implicated in many cases. However, microorganisms that comprise the vaginal flora have also been associated with pelvic inflammatory disease. Cytomegalovirus, or CMV, Mycoplasma hominis, Mycoplasma genitalium, and Ureaplasma ureaticum might be associated with some cases of PID as well. Pelvic inflammatory disease is most often seen in young single women that are sexually active with a history of sexually transmitted diseases. The exact incidence of PID is unknown because it's difficult to diagnose definitively based on clinical signs and symptoms. Symptoms include fever, vomiting, back pain, dyspareunia, and bilateral lower abdominal pain, as well as symptoms of the lower genital tract infection, such as abdominal vaginal odor, itching, bleeding, and/or discharge. The primary treatment goal is the eradication of pathogenic organisms that are associated with infections that are commonly implicated in PID. The pathophysiology will be discussed next. The development of the upper genital tract infections is mediated by the failure of a number of defense mechanisms that are usually effective in the prevention of PID. Virulence of the organism, size of the inculum, and the defense status of the individual determine whether an infectious process results. Gonorrhea and chlamydia are the main infectious causes of pelvic inflammatory disease. These microorganisms can infect the vagina and cervix, but do not usually ascend into the upper genital tract and cause PID. However, when the normal vaginal microflora is disrupted, the pathogens can more easily ascend through the cervix. There are many anaerobic bacteria that have been implicated in increasing the risk of PID because they alter the pH of the vaginal environment and may decrease the integrity of the mucus blocking the cervical canal. As previously stated, the primary pathogens in PID are chlamydia and gonorrhea. However, the disease is polymicrobial and is treated by broad-spectrum antibiotics to ensure the causative agents are eliminated. Once the infection is established within the uterus and/or fallopian uterine tubes, the infection may induce changes in the columnar epithelial lining, the upper reproductive tract, causing permanent damage. The resultant inflammatory response causes localized edema and/or occasionally obstruction or necrosis of the area. Gonorrhea attach to the fallopian tubes and excrete a substance that is toxic to the tubal mucosa, which causes further inflammation and damage. Chlamydia enters the tubal cells and replicates, bursting the cell membrane as it reproduces, causing permanent scarring. Gonorrhea and chlamydia can spread to the abdominal cavity, the openings of the fallopian tubes, and uterine tubes. Other mechanisms that may contribute to PID include lymphatic drainage with perimetrial spread of the infection, sexual intercourse, and retrograde menstruation. This next slide is an image that depicts the development of pelvic inflammatory disease. I'll let you guys review that on your own, but it is very helpful. Next, we're going to talk about common presentation. The cardinal presenting symptoms of women with pelvic inflammatory disease is lower abdominal pain. Usually the abdominal pain is bilateral and rarely more than 2 weeks duration. The character of the pain is variable and can be subtle. The onset of pain during or shortly after menses is particularly suggestive of PID. The most common signs and symptoms of pelvic inflammatory disease include abnormal vaginal discharge, pain of the lower abdomen, often a mild ache, pain in the upper right abdomen, abnormal menstrual bleeding, fever and chills, painful urination, nausea and vomiting, and painful sexual intercourse. The approach to a patient with pelvic inflammatory disease, or PID, should begin with a history which should focus on identifying risk factors for PID. A physical exam should then be completed, which includes a clinical examination followed by a speculum examination. Diagnostic evaluation is frequently needed because incorrect diagnosis and management might cause unnecessary morbidity, and additional lab testing may be conducted if a patient is not responding to initial treatment. Imaging is generally reserved for patients with uncertain diagnosis and those who are severely ill and unresponsive to initial therapy. Empiric treatment of PID should be initiated at first consultation in sexually active young women and other women at high risk of PID, those with individual risk factors, and those connected to networks with the incarcerated, to the commercial sex trade, or to drug use. Differential diagnosis for pelvic inflammatory disease includes ectopic pregnancy, ovarian cyst rupture or torsion, endometriosis, cystitis, appendicitis, diverticulitis, irritable bowel syndrome, and functional pain. There are suggestive features for each of the differential diagnoses. Ectopic pregnancy suggestive features are history of Miss Menzies and positive pregnancy test. Ovarian cyst rupture and torsion suggestive feature is sudden onset of severe pain. Endometriosis suggestive features are cyclic or chronic pain. Cystitis suggestive features are urinary frequency and or dysuria. Appendicitis suggestive features are pain localized to the right iliac fossa and vomiting. Diverticulitis clinical features is bowel symptoms in older women. Suggestive features of irritable bowel syndrome are generalized abdominal pain, constipation, and diarrhea. Functional bowel pain suggestive features are other causes have been excluded. The next slide is an image of an approach to women with acute pelvic pain from the American Family Physicians. I really suggest that you guys look at it. It's a great resource that we can look at for if we do have women that have pelvic pain. Immediate actions. Pelvic inflammatory disease should be suspected in any young and or sexually active female patient that presents with lower abdominal pain and pelvic discomfort. The suspicion for PID should be high, especially in adolescents. The goal of the initial evaluation of women with suspected PID is to establish presumptive clinical diagnosis of PID, then assess for additional findings that increase the likelihood of that specific diagnosis, and evaluate for other potential causes of pelvic pain. A presumptive clinical diagnosis of PID can be made on the basis of history and physical findings alone, although lab testing is also done at the initial evaluation of all patients suspected of PID. And empiric treatment should not be delayed while awaiting results of these supportive tests. History. When taking a history on a patient with potential pelvic inflammatory disease, the history should focus on potential risk factors for pelvic inflammatory disease. Particularly, a sexual history should be taken, which includes assessing for new sexual partners as well as consistent use of condoms. Additional assessment of history should clarify the onset and character of pelvic pain. The onset is usually recent, and the pelvic pain is usually constant and aching. It's important to understand that even subtle and mild symptoms can be consistent with pelvic inflammatory disease. Other symptoms, such as urinary and gastrointestinal symptoms, may indicate an alternate diagnosis to be sought. My next slide is about red flags. In patients with chronic pelvic pain, red flag findings that require evaluation exclude severe systemic disease and or malignancy, include postcoital bleeding, postmenopausal bleeding or onset of pain, unexplained weight loss, pelvic mass, and hematuria. Complications of pelvic inflammatory disease, but are not limited to recurrent pelvic inflammatory disease, hydrosalpinx, chronic pelvic pain, infertility, ectopic pregnancy, and ovarian cancer. Women with a history of PID are at increased risk of recurrence. After PID resolves, the fallopian tube that is damaged can become blocked, fill with sterile fluid, and become enlarged, which result in hydrosalpinx. Chronic pelvic pain is a pain that occurs below the umbilicus that is severe enough to cause function disability, and as many as 1/3 of women with PID develop chronic pelvic pain. Both symptomatic and asymptomatic PID can cause permanent injury to the fallopian tube. Changes in the fallopian tube, including the loss of ciliary action, fibrosis, and occlusion, lead to tubal infertility. Tubal damage caused by PID increases the risk of tubal pregnancy. A study that was conducted in Taiwan reported that a history of pelvic inflammatory disease increased the risk of ovarian cancer by almost twofold. And this will also be discussed later in my evidence-based practice research. The most important risk factors for pelvic inflammatory disease is prior infection with chlamydia or gonorrhea. Other strong factors for pelvic inflammatory disease include young age at onset of sexual activity, unprotected sexual intercourse with multiple sexual partners, prior history of pelvic inflammatory disease, and IUD use. Weak risk factors for pelvic inflammatory disease include smoking, low socioeconomic status, current vaginal douching, and intercourse during menstruation. Physical and pelvic exam. All women that present with suspected PID should have a bimanual exam to evaluate for cervical motion, uterine or adnexal tenderness. In addition, a speculum exam should be completed to evaluate for cervical mucopurulent discharge. A defining characteristic of acute symptomatic PID is pelvic organ tenderness. If there is a palpable adnexal mass, it may be suggestive of a tubo-ovarian abscess complicating PID, but it could also reflect other disease processes in the differential diagnosis of PID. To review physical and pelvic exam of PID, the key diagnostic factors include uterine tenderness, cervical motion tenderness, and adnexal tenderness. Other diagnostic factors to consider include lower abdominal pain, abnormal cervical or vaginal discharge, fever, and nausea and or vomiting. Diagnostics. The tests that should be performed on all women that are suspected of having pelvic inflammatory disease include pregnancy test, microscopy for vaginal discharge, nucleic acid amplification test for C. Chlamyditis and gonorrhea, NAATS for Mycoplasma genitalium, HIV screening, and sclerogenic testing for syphilis, complete blood cell count, polymorphonuclear cells on a wet mount of vaginal secretions, and serum erythrocyte sedimentation rate should be ordered as well. Tests that should be considered include transvaginal ultrasound, pelvic CT, pelvic MRI, and laparoscopy. This next slide is from the Centers for Disease Control and Prevention, and it is diagnostic criteria for pelvic inflammatory disease. I highly recommend that you go back and review that on your own, and there is a discussion question on that. Treatment goals. The primary treatment goal for PID is the eradication of pathogenic organisms that are associated with infections that are commonly implicated in PID. Treatment regimen for PID must provide empirical broad-spectrum antimicrobial coverage. There is no single antibiotic that is adequate to treat pelvic inflammatory disease. Therefore, combination therapy is necessary. Availability, cost, patient acceptance, and antimicrobial susceptibility must be considered when determining a treatment regimen. It's estimated that 25 to 75% of PID cases are caused by gonorrhea or chlamydia. Therefore, most treatment regimens should be directed towards these specific bacteria. The first-line treatment options for PID include ceftriaxone 250 mg IM as a single dose and doxycycline 100 mg oral twice daily for 14 days. Next is cefoxitin 2 g IM as a single dose and probenecid 1 g orally as a single dose and doxycycline 100 mg orally twice a day for 14 days. And lastly, cefotaxime, 500 milligrams IM as a single dose, and doxycycline, 100 milligrams orally twice a day for 14 days. Current guidelines from the Centers for Disease Control and Prevention recommend that for the treatment of PID, an addition of metronidazole for full coverage against anaerobes and bacterial vaginosis be included in all women diagnosed with PID. Prevention. The primary prevention for the acquisition of PID is behavior change. As modifiable risk factors that are associated with PID, patients that are considered high risk should be counseled on safe sex behaviors, which includes the use of condoms, and the high risk of infection with sexually transmitted infections. Where appropriate, counseling for HIV as well as testing should be completed. Secondary prevention includes evaluation and treatment for men who have had sexual contact with a woman that's been diagnosed with PID during 60 days prior to the onset of symptoms. Treatment regimens should be directed towards treatment that is effective against chlamydia and gonorrhea. Women should be counseled to avoid sexual intercourse until themselves and their partners have completed their treatment course. If adequate screening for gonorrhea and chlamydia in sexual partners is not possible, empiric therapy for gonorrhea and chlamydia should be prescribed. Next, I'm going to get into my evidence-based research articles. The first study that I'm going to discuss is a Cochrane review from 2017 that assessed antibiotic therapy for pelvic inflammatory disease. There was a total of 6,348 participants, which were all women, and there were a total of 37 randomized controlled trials. To be included in the study, the randomized controlled trials had to compare the use of antibiotics with a placebo or other antibiotics for the treatment of PID in women of reproductive age, either receiving treatment inpatient or outpatient. The review was limited to the drugs of use that are recommended by the CDC in their 2015 guidelines for the treatment of PID. The antibiotics that were assessed include azithromycin, doxycycline, quinolone, cephalosporin, nitronamidazole, and clindamycin, plus aminoglycoside. Overall, the study found that there was no conclusive evidence that one antibiotic regimen was safer and or more effective than the other to cure PID. The second study that I'm going to discuss is a meta-analysis from 2017 to determine the risk of ovarian cancer in patients that have been diagnosed with pelvic inflammatory disease. PubMed, Embase, and ISI Web of Science databases were searched through October of 2016 for studies that investigated association of PID and ovarian cancer. There were a total of 13 studies that were eligible for analysis, which included 6 cohort studies and 7 case control studies. Age was the most important co-founder. Additionally, all studies were adjusted for family history of ovarian cancer, use of oral contraceptives, education, and menopausal status. All of the cohort studies used hospital records, whereas all the case control studies used self-reported PID history collected via interviews and questionnaires. Overall, the meta-analysis did find that PID is associated with an increased risk of ovarian cancer, which has been previously found in other studies as well. The third study that I'm going to discuss is a 2018 retrospective study on how to differentiate acute pelvic inflammatory disease from acute appendicitis in women with abdominal pain and inflammatory syndrome. There were contrast-enhanced CT studies reviewed on 109 women with acute PID and 218 age-matched women with acute appendicitis, or AA. These studies were retrospectively and independently reviewed by 2 radiologists to identify CT findings predictive of PID or AA. Following the review, a CT decision tree using the classification and regression tree, or CART algorithm, was generated. The results concluded that according to the decision tree, an appendial diameter greater than 7 millimeters was the most discriminating criteria for determining acute PID and AA, followed by a left tubal diameter greater than or equal to 10 millimeters with a global accuracy of 98.2%. Next, we're going to talk about patient education. Patient education is an essential component in the treatment of women with pelvic inflammatory disease. Patient education must provide clear information about diagnosis, which includes transmission and sequelae. Education should also be provided on the need for completion of therapy regardless of symptoms, timely follow-up, and partner treatment. It's also helpful to encourage the patient in appropriate medical care seeking behavior, including seeking care immediately when symptoms recur. Patients need to be educated on behaviors that increase the risk of PID, also increase the risk of HIV infection. Rates of recurrent PID, chronic pelvic pain, and infertility have shown to be the highest amongst non-persistent condom users. Referral for HIV testing and counseling is recommended, as well. Finally, information about prevention of future infections must be reviewed and repeated at follow-up visits. And follow-up should be completed within 48 to 72 hours, which we'll get into next. Close follow-up for a patient with pelvic inflammatory disease is essential. If outpatient therapy is selected, it's important that the patient be reevaluated in 48 to 72 hours to ensure that clinical improvement has occurred. Indications of clinical improvement include reduction in abdominal tenderness and reduction in cervical motion tenderness. If no clinical improvement has occurred after 48 to 72 hours of treatment, further diagnostic evaluation for complications such as pelvic abscess or for alternative diagnosis. Patients that are initially treated as outpatients and show no improvement warrant hospitalization and parenteral therapy. For those that are already receiving parenteral therapy, the initial treatment regimen should be evaluated to ensure that appropriate coverage is being provided if necessary, and to then adjust the regimen if necessary. Referral/hospitalization indications. Referral for hospitalization of a patient with PID is indicated if there's a surgical emergency such as appendicitis or ectopic pregnancy that cannot be excluded. The patient is pregnant. The patient has failed to respond clinically to outpatient therapy. The patient is unable to tolerate an outpatient regimen. The patient has severe illness, nausea and vomiting, or a high fever. The patient has TOA. The patient is immunodeficient. Now for referral. Gynecological and surgical consultation is indicated when the diagnosis is unclear. Unilateral pelvic pain or mass is a strong indication for laparoscopy, which is one of the surgical treatment options available for PID. In conclusion, pelvic inflammatory disease is comprised of a spectrum of inflammatory disorders of the upper female genital tract, which include combinations of endometriosis, spelpingnitis, tubo-ovarian abscess, and pelvic peritonitis. There are many microorganisms that are associated with pelvic inflammatory disease. However, the most common are gonorrhea and chlamydia, as we've previously stated. In all cases, pelvic inflammatory disease, it's important to begin empiric antibiotic therapy before results are obtained from diagnostic testing. The primary treatment, of course, then is antibiotics, of which there are many options. The overall goal of treatment is the eradication of pathogenic organisms that are associated with infections that are commonly implicated in PID. If referral is indicated, it's often to OBGYNs. It is important to note that when dealing with patients with pelvic inflammatory disease, diagnostic evaluation is needed because incorrect diagnosis and management might cause unnecessary morbidity. It's also important to follow up with patients in 48 to 72 hours to ensure clinical improvement. And that is my presentation. Next, I'll go through the discussion questions really quick, and then my references will be available. My questions begin. How common is pelvic inflammatory disease in the United States? How is pelvic inflammatory disease diagnosed? Discuss a differential diagnosis for PID and explain how would you differentiate PID and the differential diagnosis. What are the treatment options for PID other than what was discussed within the literature review? How would treatment differ for patients that are inpatient versus outpatient? What diagnostic tests are used for pelvic inflammatory disease, and when are these tests indicated? Is there a genetic factor associated with PID, and if so, please explain how genetics is a factor in the acquisition of PID. Provide an overview of potential complications for pelvic inflammatory disease, both short and long term. According to the CDC guidelines, when is empiric antibiotic therapy indicated for treatment of pelvic inflammatory disease? What is the role of bacterial vaginosis in the etiology of pelvic inflammatory disease? How do contraceptives affect the incidence and severity of pelvic inflammatory disease? discuss the prevention of pelvic inflammatory disease in a young sexually active female, and provide education on pelvic inflammatory disease with a young sexually active female. That's my presentation. Thank you guys for listening.